Okay, so we were starting to talk just a little bit about mania, I believe. I think. So let's talk a little bit more about mania. We'll talk about bipolar disorder. Then we're going to jump to schizophrenia. And so like we were talking about, I'm going to get rid of all this. I will continue to talk about the final and the final paper and all that good stuff through the next week, so don't worry about that. But we started to talk just a little bit about mania, as far as I can recall. And on Tuesday, yeah, that's pretty much where we were. If we were not here, hopefully you guys yelled at me, but in order to, okay, I shouldn't start with that. Again, we talked about unipolar, again, poles, not spectrum. We talked about, okay, good. Okay, we talked about unipolar disorders, and we talked about bipolar disorders. So again, you got depression on one end of the pole, you have mania on the other, and so we only talked about, like, okay, you just have depression. You don't have any mania. That could result in a major depressive disorder diagnosis. Now, when somebody experiences mania and depression, now we're into the realm of bipolar mood disorder. I'm feeling deja vu. How far did we get into this? Did we get a long listen to this? Is anybody else getting a deja vu? I'm probably getting deja vu because I literally talked to Mary's class exactly these exact words yesterday, so maybe that's why I'm getting deja vu. Sorry, people on video. Okay, so now we're into bipolar disorder. You're going to experience both poles, and so in regard to that, in working toward a bipolar 1 diagnosis, which is going to be the most common bipolar disorder, we need to have a manic episode. And truly, in regard to the diagnosis of a manic episode, that is really all you need for bipolar 1 diagnosis. Obviously, it's going to get in the way of your functioning, that kind of stuff, but I digress. So with a manic episode, which is needed to diagnose bipolar 1 disorder, you have to have what's called an elevated or expansive mood for at least 1 week with 3 symptoms. So, again, we got, yeah, I can't write. Okay? 1 week, 3 symptoms. Or, if the mania gets bad enough, hospitalization. Because there are situations in which somebody's mania, it borders on psychosis, or it's just that bad that somebody might need to be hospitalized. Which is a positive thing for mania because, again, mania, people who are manic, they make decisions and do things that wouldn't normally do, and it's hard to control those behaviors. So, if somebody is manic and they get 3 days into their mania and somebody's like, you need to be hospitalized, and they are hospitalized, that still counts as a manic episode, even though they didn't make it the full week. So hospitalization, if it occurs before that 1 week period is hit, it's still a manic episode. So in regard to, okay, what are the symptoms of mania? You have to have at least 3 of these to be diagnosed with a manic episode, again, plus hospitalization or 1 week of symptoms. Again, for most of the day, for the majority of the day. First one, inflated self-esteem or grandiosity. I am Jesus. I am the best thing that ever happened. I am the smartest. I am the most beautiful. I am the strongest. Again, it's that grandiosity. You think incredibly high of yourself. And again, you have to consider somebody's baseline. If this is how somebody acts already, it has to be even more so. It needs to be taken to an extreme. All right. Second one, decreased need for sleep. Yes. Somebody who is in the bouts or having a bout of mania, they don't need to sleep because what's happening during mania is that neurotransmitters are just constantly firing, like dopamine, glutamate. It's just ravaging the brain, so to speak. And so I'm going to tell you about one of my buddies. He hadn't slept for 5 days. Had not slept for 5 days. They're going to be more talkative than usual. Again, you gotta go with the baseline. If this is already somebody that's talkative, they have to talk more than usual, more than what they normally do. So they're going to talk. And then they're going to have flight of ideas or racing thoughts. So maybe, and that's where these kind of go together. If there's a flight of ideas or racing thoughts, they're probably already distracted in that they cannot stay on track with a conversation. You might be talking about something, and then all of a sudden they're talking about something else, and then something else. So that distractibility commonly will come into play with those racing thoughts. But yeah, with the distractibility, okay, yeah, squirrel, shiny object, they cannot focus. Also, and these are ones that you're going to also notice very commonly, an increase in goal-directed, that's supposed to say activity. It gets me every day. Activity, not activated, but goal-directed activities. So, this is part of that reason why some people are like, I wish I could be manic for a while, because I won't need to sleep and I'll get a lot of stuff done. Maybe, but also, I'm going to say, again, mania is not pleasant, because it's a crapshoot. Yes, that goal-directed activity, maybe you do like write your dissertation. Or, I gave this example yesterday, maybe you're like, I'm going to start a DVD business, a DVD player business. You go and buy 20 broken DVDs, you take them home, you take them apart, and you have no idea how to put them back together. Now you have you got pieces of 20 DVD players in your house. That counts too. And again, it's a crapshoot. Your brain might be doing different things. And also, there is excessive involvement in activities that have a high potential for negative consequences. I'll keep going. So again, considering somebody's baseline, they might take part in excessive, risky sexual behaviors, excessive drug use, spending is going to be fairly commonplace. Maybe somebody goes and maxes out a $10,000 credit card in 24 hours. That would be something that would be fairly common amongst individuals in a manic state, putting themselves potentially in danger or other people in danger. So, reckless behavior. And again, you only need 3 of these. You only need 3 of these for a week or hospitalization. Okay, with that manic episode piece, do you guys have questions about that right now? Okay, and obviously, if you are having these symptoms and they are excessive compared to what you're used to, you're gonna have impairment. Either maybe you need to be hospitalized. Maybe you have there's dysfunction in your life because maybe you've disappeared from your family and you hopped on a plane and flown to Germany or something like that. Because why not? There could be relationship issues. You max out a credit card. Okay, that's going to cause financial issues. And please tell me that, really, that's going to cause some relationship issues. I'll put money on it. And then occupational issues. Yeah, if you are manic, you're going to have a hard time. If you go to work, focusing at work, doing your job, or maybe you just don't go to work anymore. Or you quit your job because why not? You're manic. And it's not attributable to the effects of substance abuse or other medical conditions. So, one common, again, when I was working at Region 2, I had to be able to delineate between, somebody who had bipolar disorder and was using methamphetamine. Are they manic or are they using meth? Because the side effects of meth can look similar to those of mania. So that was something else that I kind of had to suss out. So that is a manic episode. And again, this is what we conceptualize these episodes with mood disorders because they're kind of like puzzle pieces. You plug in the episodes into a variety of disorders to come to a conclusion about a diagnosis. So, what did I do? For bipolar 1 disorder, all you need is one manic episode. And obviously the mania is not better explained by another psychological disorder. One episode is all you need for a bipolar 1 disorder. That's it. And what's interesting about this is with a bipolar 1 diagnosis, you don't have to have any depression, or the clinician doesn't have to notice any depression. But I will say I have never met anybody that does not experience depression as well. You just don't need it for the diagnosis. Because commonly, bipolar disorder does look something like this image right here, and that euthymia is your baseline, and so somebody might experience, again, those manic symptoms, and then, okay, we're on the way back down and we're crashing into depression. We're in depression for a while. Then maybe we'll come back up to baseline, maybe, and then maybe we'll drop into a depression, and then we're back up into mania. And so I've never met anybody without depression and bipolar 1. You just don't need it for a diagnosis. But I'm assuming it is possible to only have manic episodes. I just have not met anybody like that. So that's going to be bipolar 1 disorder. And again, bipolar 1 disorder specifically diagnosed based upon a manic episode. Any questions about bipolar 1 disorder right now? Okay, one thing I am going to make a note of here. Okay, in regard to treatment, it's not on this PowerPoint. Why? I don't know what I did. But in regard to treatment for bipolar disorder, bipolar 1 disorder, this is one of those diagnoses you have to take medication. You've got to take medication. This, and again, in regard to a couple of diagnoses where you have to take medication, because with depression, maybe you need medication, but you're also going to do therapy, anxiety, and maybe some therapy and maybe a little medication. Bipolar disorder and schizophrenia, you have to take medication. All right? So you got to take medication. And commonly, what somebody with bipolar disorder is going to be medicated with, because in most cases they're going to also be depressed, they're going to get an antidepressant, which we kind of talked about on Tuesday. So you're going to get an antidepressant, and then commonly you're either going to get a mood stabilizer or possibly a neuroleptic, also known as an antipsychotic, depending on how severe the mania is. Because what the mood stabilizer and the antipsychotic does is calm everything down in the brain. Because there's excessive neurotransmitter activity during mania, that both of those types of drugs will calm everything down a little bit. So some of the common mood stabilizers that people might be put on: Lamictal, Depakote. Oh man. Also lithium. That is a traditional go-to. Is going to be lithium. And lithium, it's not like a brand name. Lithium is what it sounds like. Lithium is lithium. Lithium is like the mineral or ore or substance that you actually find on Earth. And we talk about like lithium-ion batteries. It's lithium. It is literally lithium. And again, what lithium also does is it tamps down those manic symptoms. And only thing is with lithium, obviously there's going to be long-term side effects. We are not made to ingest lithium, but it does aid in helping to control some of those manic symptoms. Okay, so you might get an antidepressant, you might get a mood stabilizer, or again, you might get an antipsychotic, and that's what we're going to talk about with schizophrenia. But with antipsychotics, you might get like Vraylar. You might get like Geodon. If we go old school, maybe you're getting Haldol. I think Prestige, or is Prestige an antidepressant? I can't remember. But those, okay. Thanks, Seroquel is an antidepressant. It's either an antidepressant or mood stabilizer. I apologize. Those are a couple examples of antipsychotics. And again, what's hard about bipolar 1 disorder is medication compliance. Because what happens with some people, when they're experiencing mania, they feel good. They feel euphoric. And so, in some cases, they become medication non-compliant because they feel good now. Or they want to experience their mania, and so they stop taking their medication. But again, mania is not always pleasant. For some people, yeah, they might experience euphoria, but for other people, it could be just a lot of irritability. That is also common in mania. So it's not great. You don't want this. Oh, what else do I have? And of course, in conjunction with medication for bipolar disorder, you're going to want like cognitive behavioral therapy as well. Okay. You guys have any questions about bipolar disorder? And again, I know that these are pretty shallow and short explanations of some of these disorders. If you're interested, abnormal psychology spends 16 weeks. With every single one of these categories, I spend an entire week on them. So if you're interested in these, think about that. I think it's a super fun class. But, okay, schizophrenia. All right, we're moving from mood disorders to psychotic types of disorders. And the only one we're going to talk about here is schizophrenia. I mean, for a second we'll talk about brief psychotic disorder, and then we'll talk about schizophrenia. We're going to skip out on schizoaffective disorder. Schizoaffective disorder is commonly conceptualized as a mixture between schizophrenia and bipolar disorder. So you have a psychotic disorder, plus you have a mood disorder, and then schizophreniform disorder. We're not going to cover in this course, but it is there. Okay, first thing we have to cover when we're talking about schizophrenia is we have to talk about what psychosis is. Because there has to be symptoms of psychosis if you are going to be diagnosed with schizophrenia. Or a psychotic episode, for that matter. So, just to note here, when we're talking about these things, positive does not mean good and negative does not mean bad. At all. But when somebody is in a psychotic state, they're going to have an inability to differentiate between what is real and what is not real. So and again, as time goes on, and if they're in treatment for long enough, they may be able to kind of recognize, okay, the fact that I'm seeing faces and floating in the wall is not right. I just gotta wait it out. But part of psychosis, until you get to that point, is you can't tell what is real and not real. So their hallucinations, they might perceive them as real, or their delusion that the FBI is after them is real to them. This is real. That's what is taught about psychosis. Okay, so when it comes to the symptoms of psychosis, they're divided into two groups. We have positive symptoms and we have negative. When we talk about positive symptoms, think of it as like a plus sign. Not like positive, think of it as a plus sign. You are adding something that should not be there. We're adding something. So just some examples, I'll go into more depth about them, but some positive symptoms of schizophrenia are going to include delusions, which is something added that should not be there, hallucinations, again, added that should not be there, or disorganized thoughts. Again, an additional type of thought that should not be present. On the other hand, negative symptoms, think of it as like a minus sign. Just think of it as like a minus sign. You're subtracting something that should be there. So with negative symptoms, you might have a reduced speech, so you're not talking as much. Your capacity to speak is lessened. You might have a lack of emotional and facial expression, so this is when your affect becomes a little bit more flat. And so if you're in a situation where you should be sad or you should be happy, you just kind of look like you're deadpan, like you can't express those emotions. Also a diminished ability to begin and sustain activities. This is going to be abolition, amotivation. So you have a hard time getting started doing anything. And if you notice here, some of these negative symptoms may be perceived as depression. And some of them are, but again, they're going to be the negative symptoms of schizophrenia. Decreased ability to find pleasure in everyday events. Again, that would be the depression-related symptoms. Anhedonia. Tacos and puppies don't feel good anymore. Also, social withdrawal, asociality. You are no longer reaching out to friends. You're not going out. You're not going to, you're not going to social events. You're just not interacting with people as much anymore. Okay, and something about this is commonly when we're starting to look at schizophrenia, hindsight is 20/20. So once somebody becomes diagnosed with schizophrenia, they are usually exhibiting the positive symptoms of schizophrenia. So they are hallucinating, they are delusional. But when family and friends look back on maybe the previous 10 years, 5 years, 2 years, what they kind of start to notice commonly is that, no, they've had negative symptoms for years. We call that a prodromal phase of schizophrenia, and that these negative symptoms do commonly pop up before the positive ones do. It's just that when these negative symptoms pop up, parents or people around them are no, they're just depressed. Maybe they got depression. They don't necessarily think no, it could be the start of schizophrenia. Most people don't think that. And additionally, when a lot of these symptoms start to, because kind of the prime time, and I might be missing it a little bit off on this, you're looking at schizophrenia symptoms start to become more prevalent late teens, early 20s. And so if you're a teenager and you're starting to act like everything in the orange here, your parents are going to be like, okay, they're a depressed teen. They're acting like a teenager. They're not interacting with me as much. They don't want to do their homework. They don't want to talk as much. There's just no real emotional reaction. When I talk to them, they're like, no, they're just depressed. They're fine. Not necessarily. They could be having these negative symptoms, which are going to be the start of schizophrenia. Again, we call that a prodromal period. I'll put that on the board because I don't have it. It's prodromal period. Okay, so these are, and when I ask questions about psychological disorders on your exam, I will probably ask things like, okay, tell me what positive symptoms are, tell me what negative symptoms, give some examples, things like that. It's going to be fairly, not easy, not overtly challenging, though. I'm not going to ask you to diagnose something. That's abnormal psychology. Okay. So again, positive symptoms. We got like delusions and hallucinations. Obviously, the disorganized thought and speech we'll talk about, but delusions and hallucinations are going to be two of the overt behaviors that you might notice in somebody with schizophrenia, especially if they are having a psychotic episode. In that delusions are going to be ideas that an individual believes to be true but are highly unlikely or impossible. But they're convinced that this is reality. That's the thing about this. They know that this is reality, but it's not. So I've got a list of delusions that I'll kind of go over to give you an idea. But maybe they think, again, maybe the CIA or FBI is truly after them. And again, this is their reality. This is absolutely their reality. Or they believe that they are the second coming of Jesus Christ. And again, they're not joking about this. They're not lying about this. They're not trying to scam or manipulate somebody. They truly believe this. Like, it is reality to them. They're not making this up. And then hallucinations are going to be perception-like experiences that occur without external stimuli. So again, we talked about insensation and perception. When our senses are activated, that's when the brain is able to sort out that information and we perceive something like, oh my God, the color of this piece of paper is pink. Okay, that's real, that's happening right now. That is part of our reality, okay? And that's because our senses are activated and we are able to perceive what is happening here. When there's a hallucination, there is no external stimuli to activate the senses. But what's happening is that those senses are being activated, those areas of the brain are being activated, and somebody is perceiving something that is not there. And the cause of these hallucinations, and delusions for that matter, is again, it's going to be the result of excess dopamine and glutamate in the brain. So it looks like their brain is on fire. And so if there's excessive dopamine or glutamate, let's say that's active in like the visual cortex. What that's going to do is it's going to produce visual hallucinations. Because again, there's so much stimuli in that area of the brain's like, okay, there's something there, and there isn't. So they are perceiving something in the environment that is not there. Again, like dead Uncle Fred, or I smell tacos right now when there's no tacos being made, or I can hear music, there's no music. Those are positive symptoms. Again, there are things that should not be there that are there. We're adding symptoms that should not be there. It's something that we're adding to somebody's experience in the world. And these are just some types of delusions. I'll just go over a couple of them. You guys have access to them if you're interested. But like a persecutory delusion. Okay, this is like the CIA or FBI are conspiring to catch you in a sting operation, but you haven't done anything. But they're still going to get you. They're going to get you for something. Let's see here, like a delusion of reference for this, okay? Like, it's the belief that events, objects, or other people have an unusual personal significance. So, if like, maybe a newscaster is reporting on your movements, or that a random manhole cover was put there so you could see it. Again, things in your environment that are just basically normal, you perceive as being important. Like, they put that there for me to see. That traffic cone, They put that there for a reason, for me to see it. There's a reason that it's there. Let's see here. Grandiose delusion. Again, that's going to be a common one as well. The false belief that you have great power, knowledge, or talent, or that you're a famous and powerful person. Yes, you are Martin Luther King reincarnated. Maybe you're Kim Kardashian. Who knows? Let's see here. Delusion of being controlled. An example of this. An alien has taken over your body and is controlling your behavior. Thought broadcasting. Basically the belief that your thoughts are being transmitted via the internet against your will. But basically they're being transmitted in some way, like what I'm thinking right now is being transmitted so everybody else can hear it. Nobody wants to hear that, by the way. But that's what they do. And again, they're convinced of this. Again, this isn't their fault. This is not their fault at all. This is how their brain is just acting and functioning. Thought insertion. Maybe this could be like the belief that your spouse is inserting blasphemous thoughts into your mind. Somebody else is making me think these horrible things. Thought withdrawal. The belief that your roommate is stealing all your thoughts while you're asleep. Of course they are. No, but these are real. Delusion of guilt or sin. You believe you killed someone or that you're responsible for a disaster. There's some tornadoes around Nebraska this week. I might have committed those. I caused those to happen. That'd be an example of this. And again, they are convinced of this. This isn't just, they're not making this up. Somatic delusion. Belief that your intestines have been replaced by snakes. Horrific. Okay. So those are just some of the examples of delusions. And again, this is reality for these individuals. And again, we just talked about hallucinations. You're experiencing something for which there's not actually any stimulus. And within schizophrenia or psychosis, there is commonly a formal thought disorder. And so this encompasses, again, significant problems with thinking. They might use loose associations or derailment. So they might slip from one topic to an unrelated topic with any sort of like coherent transition. Like, okay, I'm talking about squirrels right now. Okay, I'm talking about that, Then all of a sudden I slip into talking about Gaza. And you're like, what? There's no continuity there. But again, as we just talked about with mania, you might have to determine, like, okay, what is this the result of here? This is where clinicians have to do what's called a differential diagnosis. They have to be able to consider the symptoms and possibly compare and contrast different disorders to determine what it actually is. Also, disorganized behavior is very common. This is going to be an unpredictable and apparently untriggered agitation. And it might come off as like Tourette's a little bit, so shouting, swearing. You might have somebody that's pacing as well. Also, other types of disorganized behavior include like the type of clothes people wear. I know somebody whose wife has schizophrenia, and one thing that she would do in regard to disorganized behavior, when she was psychotic, she would wear bags on her feet to go to Walmart. Maybe it's 20 below out. Maybe they're wearing shorts. So you might notice like bizarre clothing. That is a pretty good indication. Or inappropriate clothing. Again, wearing shorts and a t-shirt when it's 20 below in Nebraska, not great. And that is part of this disorganized behavior, and it does also have to do with schizophrenia. Some people with schizophrenia, like, their body's ability to recognize like a homeostatic balance isn't really there. And so they might perceive themselves as like way too warm, even though it's negative 20 outside. Like they don't have the ability, their body doesn't have the ability to distinguish that. So that could also explain it, but it's still going to kill them possibly. Okay. Okay, negative behaviors. Again, talked a little bit about those. These are behaviors things that should be there, but they're not anymore. Like you should be able to respond if somebody tells the funniest joke ever, you should be laughing. You should be laughing. That would be an appropriate response. But for somebody with schizophrenia, what might happen is that you tell the funniest joke ever, just no response. Flat affect, literally, I just think about like their mouth just kind of being flat across. Like, so severe reduction or absence of emotional expression. So they have a hard time laughing, crying, looking scared. Again, when they should, they just can't or don't. Abolitionary sociality, yes. They have an inability to initiate or persist at common goal-directed activities. Focus isn't there, motivation isn't there. Some cognitive deficits, so things like, again, lack of attention, memory, and processing speed. All of that is tamped down. So again, you have these positive symptoms where there is absolutely enhanced neurotransmitter activity in the brain. That's adding things that shouldn't be there. And then you have these negative symptoms that are, they seem to be fairly similar to depression. And that's going to be the result of a lack of those neurotransmitters. And so what you'll see people commonly do within schizophrenia, as we talked about, is that when they're in the midst of a psychotic episode, you're going to see those positive symptoms. And then in other times, you might see more of those negative symptoms. So you don't really mix the negative and positive together because they require two different types of neurotransmitter activity. Okay. I'm going to skip this one. Okay, let's talk about brief psychotic disorder for a second. Because it really offers a good transition into schizophrenia. So you have to have the presence of one or more of the following symptoms, and at least one of them has to be 1, 2, or 3. So you have to, and again, what this indicates is that you have to have at least one positive symptom. And again, this is going to be an indication that it is a psychotic disorder. If you don't have 1, 2, or 3, we're talking about something completely different. So you have to have some sort of positive symptom. You have to have delusions, hallucinations, or disorganized speech. Those are all positive symptoms. So you got to have at least one positive symptom, and then maybe you have grossly disorganized or catatonic behavior. And I didn't talk about catatonic behavior, but this is when somebody does not respond to their environment. Sometimes people with catatonia, they just kind of lay there, just kind of stand there, and they don't respond. Like if somebody jumps out at them, they're just going to stand there. And again, that has a lot to do with the lack of dopamine in the sensory motor and motor areas of the brain. And so any sort of sensation, anything they should be reacting to, they just don't. So that could be catatonia. But you don't necessarily need that, but it does add to the severity of the disorder. Now, here's what's interesting about this, is that it has to be during an episode. To get diagnosed with brief psychotic disorder, you have to have at least 1 day, but less than a month. So again, 1 to 29 days. All right, you have to have 1 to 29 days. And in general, okay, if you hit that 29 days, let's say you hit day 25, and you have recovered, and you have gone back to, you haven't experienced any more positive symptoms, again, your diagnosis will end. But if your diagnosis continues, you're going to be transitioned over to another diagnosis, and this diagnosis will fall off. That's why we have the 1 month or 1 day to 29 days, because in order to be diagnosed with additional diagnoses, you have to have symptoms for longer. So this brief psychotic disorder is kind of like a stopgap almost, in that if somebody, if they've had positive symptoms of psychosis for 2 days, good, we can diagnose them with this and we can get them treated. But again, they might not have enough symptoms that we can bump them up to the next diagnosis. Okay, so, and you have to make sure that the symptoms are not better explained by things like major depressive or bipolar disorder, because major depressive and bipolar disorder can have psychotic features. If somebody does experience severe enough mania, or even depression for that matter, they might actually have psychotic-related symptoms. So you need to ensure that it's not just a feature of those two disorders. Hold up a sec. Bipolar. Oh, there we go. Okay. I gotta check something really quick here. All right, so that's going to be brief psychotic disorder. to skip this, skip that, skip this. All right, we're going to jump to schizophrenia. And again, if you're interested, okay, if you're like, oh my gosh, why isn't she talking about these? I want to hear Courtney talk about these. If you want to continue to hear my voice, all of the lectures for abnormal psychology and all of these disorders, you can find that also on the YouTube page under the abnormal psychology button. Instead of intro, you can find it under abnormal psychology. There are lectures on every single one of these, if you want more depth. But again, the exam will just be over what we talked about. Okay, so schizophrenia. Here's what's interesting here, is that if somebody is diagnosed with brief psychotic disorder and then their symptoms do not subside, then they might get bumped up to schizophrenia as a diagnosis. This is a diagnosis that has been recognized since the early 1800s, specifically because, again, we're trying to explain why some people are hallucinating or delusional. Okay, within the DSM-5-TR, they have to have at least 2 symptoms of psychosis. So they either, okay, and at least one of the 2 symptoms has to be a positive symptom. So you have to have at least, as I'll show you, you have to have at least the hallucinations, delusions, or disorganized behavior. And then you can have negative symptoms as well, but the negative symptoms are just tougher to catch. Those positive symptoms, again, if somebody's hallucinating, that's way easier to notice as a clinician than the negative symptom of like, well, I'm having a hard time focusing. Way easier to notice somebody who is having hallucinations. Okay, so there's an acute phase, again, either before or after the onset, and symptoms are present consistently for at least 1 month. Now, that's going to be the acute phase, in that, again, that they've been experiencing these symptoms for at least 1 month. But before the acute phase, again, we talked about this prodromal period of time. This is before the acute phase, and again, most people don't really notice something is wrong during the prodromal phase. Families don't necessarily notice this. If they do, that's awesome. If clinicians notice it as like, oh, this is the prodromal phase of schizophrenia, that's awesome. But too often it is just kind of written off as depression. Also, there are residual symptoms. These remain after the acute phase. So as somebody is coming out of a psychotic episode, again, these could be just, again, those negative symptoms. Again, that's because the dopamine and glutamate, all of the neurotransmitters are functioning at such a high rate, and then all of a sudden the psychosis dips down and you have a lack of those neurotransmitters in your brain, increasing the chances of like the abolition, the asociality, the anhedonia. Because again, there is not enough neurotransmitter activity in the brain to basically hit baseline. Great. Okay, so for schizophrenia, again, all right. Again, you have to have at least one of 1, 2, or 3. You got to have the delusions, hallucinations, or disorganized speech. And then you probably have 4 or 5 too. And if the clinician can't, I mean, the clinician can also use 2 from 1, 2, or 3. Somebody's hallucinating, they also might be delusional, or there's some sort of disorganized speech. But then either per the report of the client or like family, they might be able to determine like, oh, they have been having negative symptoms, or depending upon how they're dressed, how they're behaving in the office, they might be able to notice like, okay, their behavior is very disorganized. Okay, so again, you gotta have 2 symptoms for at least a 1 month period of time, and one of them has to be 1, 2, or 3. And so okay, this is brief psychotic disorder, and I know usually BPD is something totally different, but whereas schizophrenia, okay, brief psychotic disorder, again, 1 to 29 days. But then what you'll commonly see is the rollover, if they have not returned to baseline and had a full remission from their psychosis, that will commonly be rolled over to schizophrenia, because as soon as that 30 days hits, in general, if this has not subsided, you probably can diagnose them now with schizophrenia. So no more brief psychotic disorder, now we're to schizophrenia. So again, what that brief psychotic disorder does is it fills that gap. If somebody's experiencing psychotic symptoms, it fills the gap for that 1 month period of time. We hope that with some people, they can recover from their psychosis and go back to baseline behavior, but if not, they can roll over to schizophrenia. And for a significant portion of the time since the onset of the disturbance, the level of functioning, again, in one or more areas has decreased. Like we've talked about with those 3 Ds. There's dysfunction, there's distress, and it's deviant. Again, hallucinations, delusions, yeah, that's outside of the norm of what's expected in our culture. Dysfunction, yes, if you are experiencing these positive symptoms, it's possibly going to affect, maybe you aren't going to work because, again, the FBI and CIA are after me. I'm not going outside. Absolutely not. They're going to get me. Or if I'm hallucinating, maybe I'm not leaving my room because I'm literally hearing something that's outside my door. Okay, so work, interpersonal relationships, or even self-care. You will sometimes see self-care kind of be depleted and caused by schizophrenia-related symptoms. And those could be the negative symptoms. If you have a hard time focusing, if you can't get up and do things, one thing that you might see is some people with schizophrenia, they might not shower very much, or their clothes aren't washed. So there might just appear to be some hygiene issues. So that could also be an indication as well. And again, it's below the baseline before they were diagnosed. Okay, and the continuous signs of the disturbance persist for at least 6 months. The 6 month period must include at least 1 month of symptoms that meet criteria A and include periods of prodromal or residual symptoms, which you will be able to know. During these periods, the signs of the disturbance may be manifested by negative symptoms or by 2 or more symptoms listed in criteria A. Okay, so what else do I want to say about this? What else do I have here? Oh, also you have to rule out schizoaffective disorder, depressive, or bipolar disorder with psychotic features as well. And the disturbance is not attributable to the physiological effects of a substance or other medical condition. But I do have to say, for some people that use way too many drugs for way too long, and they're like really pretty significant narcotics, it is possible to be diagnosed with substance or medication-induced psychotic disorder. So we do actually have a diagnosis for that. In that literally, and I've known a couple people like this, like they used so many hardcore drugs for so long that it resulted in substance-induced schizophrenia. So we have, our psychotic disorder, I'm sorry. We actually have a diagnosis for those individuals whose schizophrenia we believe was caused by substance use. So we have to make sure that no substances, other medical condition is possibly causing this. And also, if there is a history of autism or communication disorder, the additional diagnosis of schizophrenia is only made if prominent delusions or hallucinations are present for at least 1 month. Okay, so regarding the prognosis for schizophrenia, especially if left untreated, the prognosis is going to be fairly poor. It is one of the most severe and debilitating mental illnesses. Like, you're just going over those symptoms. Like, it's very difficult to function. It's going to be very difficult to function. Some people are able to function and live independently. Other people, they're going to need, 24-hour support, or at least people checking on them. I had several clients who did have schizophrenia. They lived independently, but I checked on them multiple times a week. I went over to see how things were doing, make sure they're taking their medication. Some people, and again, with schizophrenia, medication compliance is going to be an issue because maybe they're delusional, and the FBI, they think the FBI is after them. The FBI definitely tainted those meds. I'm not taking them. Or they have a hallucination about the meds, and so they're not going to take them. And even like their attention ability and avolition, those negative symptoms, can result in them not taking their meds. When it comes to bipolar disorder and schizophrenia, that's 2 of the most difficult things to ensure when you're working with somebody is their medication compliance. They got to take their meds. And so you will commonly see people that are going on and off their meds with bipolar disorder and schizophrenia. And again, these are two disorders. You've got to take your meds. There's really no option. Okay, so when it comes to, when somebody is psychotic, or having a psychotic episode, if at all possible, they really should be institutionalized. They really should be hospitalized in order to regain stability. But the thing is once somebody is hospitalized for one psychotic episode, the chances they're going to be hospitalized again are between 50 and 80%. So 1 out of 2 to 4 out of 5 people who are hospitalized for a psychotic episode will be hospitalized again. Fortunately, 5 to 10%, and I'm going to make sure of this in here, 5 to 10%, so somewhere between 1 out of 20 and 1 out of 10 people with schizophrenia will commit suicide. That's an exceptionally high rate. And I also failed to mention, with bipolar disorder, it is 5% will die as a result of suicide, and with schizophrenia, again, 5 to 10%. Again, these are exceptionally high rates of suicide completion. Also, when it comes to attempts, 20% of people with schizophrenia will attempt to commit suicide. So 1 out of 5 people with schizophrenia will try to commit suicide. Some people may reach stabilization between 5 and years after the first psychotic episode if they have treatment, if they're taking their medication, if they're going to a variety of therapies and groups, if they have support, if they have a home, if they possibly, if they have all of the things that they need in order to maintain stability. That's possible. But there is a high rate of medical problems within those who are schizophrenic. Especially as a result of the medications that they take. And also, you do see high rates of, not high rates, you see increased rates of substance abuse among individuals with schizophrenia, primarily because they're self-medicating. Also, when it comes to schizophrenia, here's the issue, in that with every psychotic episode somebody has, again, there's just dopamine flooding the brain. Dopamine and glutamate flood the brain. What happens during that psychotic episode, because there's so much neurotransmitter activity, there's actually physical damage done to the brain. And so once somebody has their first psychotic episode, it not only does damage to the brain, but it increases the chance of another psychotic episode. And you have the second one, there's more damage, and it increases the chance even more that there's going to be a third. And so that's why with the medication that people with schizophrenia take, it should decrease the severity and the chances of having a psychotic episode. That's really all it's for, is to decrease the chances of that psychosis. Because literally that psychosis does brain damage. They've done post-mortem studies of people with schizophrenia, and they have actually discovered that the volume of the brain of somebody with schizophrenia is much lower, is significantly lower than that of a normal brain, or somebody without schizophrenia. And so what that indicates is there is literally mass that is lost. There's that much damage that is caused as a result of psychosis. It does affect about 1% of the general population. It's pretty similar across cultures. It most commonly has its onset in late adolescence or early adulthood. It rarely occurs before adolescence or after the age of 40. You might, in some anomalous cases, you might see it before adolescence. In some strange cases, maybe after 40, but in general, if you make it to 40, you're good. It is equal in males and females. Just kind of, and again, I'll tell this one story. Okay, so, again, I kind of noted that, mental illness, spreads through my family. I have, it would be my father's cousin. So, a second cousin, approximately, of mine. So, it'd be a second cousin of mine. He was, as a kid and then as an adolescent and becoming a young man, he was an absolutely brilliant brilliant piano player. He actually went to a university on a scholarship to play the piano. Imagine that. He was just an utterly brilliant musician. Brilliant. Unfortunately, once he went to college, what happened is he started to experience, again, schizophrenia-like symptoms. And this, we're talking about like in the 60s. 60s, maybe early 70s? And again, not a great time to even be aware of mental illness. But anyways, he started to have these symptoms. Obviously, he did not finish college. He basically returned to his hometown, and as years went on, he just deteriorated. I do recall many times when he was around while I was small, but he used a lot of substances. Like you name the substance, or a substance that would have been available, he used it. I do believe he received treatment here and there, but he had a hard time staying compliant. He ended up becoming homeless, and it was almost, it might be 10 years ago. It might be a little more than 10 years ago. But about 10 years ago, he literally passed away on the street. And that one is hard for me, I think, because he didn't choose to have schizophrenia. A lot of his actions, I understand some of the people around him's response to his substance abuse, but the compassion and empathy related to schizophrenia, I still don't think we're there. I still don't think we're very far along. People with schizophrenia are going to be at a higher rate of like homelessness as well, because it's a lot of them. They have a hard time functioning. They need sometimes 24/7 care in order to stay medication compliant and stable. He didn't get that, and I don't wish that upon anybody at all. So. Yeah, we just don't have a lot of empathy for disorders like this because I think we kind of put it on the person. When the fact of the matter is, it's really heritable. It's very heritable. And so we'll talk about that here a little bit. Okay, so these are some of the biological theories of schizophrenia. And again, with the amount of mental illness that I've learned that like does run through my family, I'm pretty sure his schizophrenia was the result of genetics. And then the stressors that aided in the manifestation of the, or like the expression of those genes. I don't have much doubt. Okay, genetic transmission, and here's why I think this. Within family studies, okay, biological relatives with schizophrenia increases in individuals at risk. So yeah, if you have, the closer somebody is biologically to you that has schizophrenia, the higher the risk you have of developing it. Adoption studies, a parent with schizophrenia creates a stressful environment for children to a certain degree, but again, if you don't have that biological connection, it's not going to be as much. But it is going to be hard, potentially being adopted into a family where a parent has schizophrenia. So that level of stress could potentially manifest itself in such a way, or any, like there could be a variety of disorders in that case. Twin studies. Here we go. So there is a genetic predisposition plus biological and environmental factors that influence the manifestation of the disorder. Yes, there is a strong genetic link that exists for it, yet it occurs at about 1% of general population, but this increases to 10% if a first-degree relative has a history of schizophrenia, which is a significant difference. So if one of your parents has schizophrenia, you have a 10% chance of developing it. The risk of developing schizophrenia increases further to 40% when both of your parents have schizophrenia. So you almost have a coin flip chance of developing schizophrenia if both of your parents have it. And that indicates to me that's a lot of genetics. Yes, maybe a little bit of environment, but lots of genetics. Also, looking at genetics, monozygotic twins, so they have the exact same genetic codes, demonstrated, again, almost a 50% risk of developing schizophrenia if one has the disease. So if your identical twin develops schizophrenia, you literally have a 50% chance of also developing it. Again, that's so high. That genetically, that's so high. As far as I know, there's no disorder that is that significantly genetic in nature. And yes, studies are going to locate specific genes to the development of schizophrenia. And what this could do is this could offer possibly preventive treatment. So if you know, like, yeah, my grandfather has schizophrenia, or one of my parents has schizophrenia, or my aunt has schizophrenia, this is something I probably would do with my kids if I were to ever have them. But what you could do is you could get a genetic test to determine, like, okay, are those alterations in these specific genes present within me? If so, what that indicates is now I'm predisposed to developing schizophrenia. And so maybe as like a 14-year-old, again, you could kind of do preventive. We haven't tried this yet, but maybe you could do low doses of antipsychotics, working up to the age of 18, managing stressors, coping skills, things like that, in the hopes that that decreases the risk of that individual developing schizophrenia. So if we're able, because again, this is very genetically based. So if we're able to locate the genes and determine who has the genes and who doesn't based upon, again, family history, we might be able to decrease the severity. Because what we should be doing is trying to decrease the severity or the potential for that first psychotic episode. Because again, with every psychotic episode, it's going to increase the chances of another and the severity. So that's what the goal is. We're not there. We're not there at all. All right, here's your genetic relatedness. And again, this is a little bit different than the previous slide, but just it's close. Identical twin, again, almost 50%. Offspring of parents with schizophrenia, almost 50%. Your fraternal twin, that drops all the way to 14%. Again, indicating that genetics make a difference. If the genetics are altered just a hair, you drop, again, from identical to fraternal twin, you have less of a genetic match. You drop almost from 50% to 14% now. So you can see the drop as you get further away genetically, which again indicates that it's very genetically based. Sibling, or offspring of one parent, 13%, sibling 10%, nephew or niece 3%, spouse 2%. I think that's just because of the increase of stressors in your environment. I'm pretty sure that's why. And then general population 1%. Okay, so this is the brain comparison of two twins. One has schizophrenia, one does not. The left side does, the left twin does not, right side does. Okay, we're looking at the ventricles here. Those are those big structures in the center of the brain here. The schizophrenic twin has cerebrospinal fluid-filled cavities located in the center of the brain. These are ventricles. So what this means is people with schizophrenia have lighter than normal brains. Because again, brains, again, are composed of, like, they're mass. White and gray matter is mass. And in regard to these fluid-filled ventricles, again, the larger the ventricles, the less mass the brain has. The less gray and white matter they have, because those ventricles are taking up so much space. We only have so much space in our skull. This can put pressure on the surrounding brain tissue as well, affecting its functioning. It also creates certain imbalances in important chemicals, things like dopamine, affecting emotions and mood. Absolutely. And the hippocampus and adjacent regions of the brain show some reduction in size. This could change the sensory filtering that takes place in this region of the brain. So again, these enlarged ventricles in general are going to put pressure on the brain, and they're going to change the way the brain is really structured and the way it functions. So that could be correlative. Let me see. That could be correlative to the development of schizophrenia. Okay, a couple of other, I have to give you a couple of other theories in regard to schizophrenia too. Birth complications, prenatal exposure to viruses also affect brain development, increasing the chances of schizophrenia. Also, there are neurotransmitter theories in that excessive levels of dopamine, and we know glutamate now, even though it's not on here, contribute to schizophrenia. And so again, what people are going to be prescribed are going to be, again, they're called neuroleptics or, phenothiazines, or they're antipsychotics. Primarily second generation antipsychotics, and what these antipsychotics are doing is they're blocking the reuptake of dopamine, thus decreasing the functional level of the brain. Again, we're after those positive symptoms, we're decreasing those positive symptoms. The less dopamine function in the brain, the less chances of those positive symptoms. And yeah, any sort of drugs that increase the functional level of dopamine are going to increase the incidence of positive symptoms. So if you have somebody who is schizophrenic that's using something like methamphetamine or cocaine, their positive symptoms are going to be that much greater. And yes, according to neuroimaging studies in individuals with schizophrenia, they have more receptors for dopamine and higher levels of dopamine, thus resulting in, again, their brain being more likely to be flooded with dopamine than somebody who does not have schizophrenia, causing those positive symptoms, the hallucinations, the delusions. Let's look at a list of these. Okay, I'm going to skip these. We talked a little bit about dopamine. Yeah, we talked about that. Okay, just for a couple seconds here before I gotta let you guys go. In general, for somebody with schizophrenia, and again, they're probably gonna be in cognitive behavioral therapy too. You're gonna want medication and you're gonna want therapy, but they're probably gonna be diagnosed with a second generation antipsychotic. These are atypical antipsychotics. These are the newest ones. So in addition to blocking dopamine, they also affect another brain chemical called serotonin, which also should decrease some of those positive symptoms. But in regard to the second gen versus first gen antipsychotics, they work about equally well, but second gens have milder movement related symptoms than first gen ones, so they have those side effects are a little bit less severe. Here's some examples of second generation antipsychotics. Abilify, how did I miss that? But Abilify, you've seen commercials for a lot of these. Abilify, Fanapt, Geodon, I've seen that used quite a bit. Invega, I've seen the commercial. Latuda, I've seen that used quite a bit. Zyprexa, I've seen commercials for both of those too. Risperdal is going to be commonly used. Rexulti, commercial. Saphris, haven't seen it. Seroquel, I've seen that used pretty commonly. And Vraylar, I've seen the commercials. So, again, you've probably seen commercials for all of these. These are antipsychotics. And sometimes clozaril, also known as clozapine, that's a second generation antipsychotic, can be used if other antipsychotics have not worked. The problem with that is that it decreases your white blood cell count a lot, and so you have to monitor your white blood cell count. So again, you can see like the side effects of these, not great. Some of the side effects that are really pretty bad: sedation, blurred vision, weight gain, tremor, agitation, stiffness, higher risk of diabetes as well. First gen antipsychotics, these are just some examples because I know I'm running out of time with you guys. Haldol is a common one, very, very common one. L'Occitane, Navane, Prolixin, Thorazine, and that was another common one. Trilofone and Stelazine. Now again, with the side effects of these, you have the chance of developing like tardive dyskinesia. These are going to be involuntary muscle movements, and you can't get rid of this for the rest of your life. That's the issue with these. These side effects suck. So it's also not outside the realm of possibility. Some people start these drugs and they're like, no, I hate the way it makes me feel. And so that's why they stop them too. We have not been able to develop, for whatever reason, neuroleptics or antipsychotics that are much more palatable for the person who has to take it. Again, these side effects are horrible. So I know I gotta stop there. But nonetheless, we'll stop there for today. On Tuesday, we will continue